Hello, welcome to the Stress and Distress in Dementia Webinar Series. This series has been developed by the Department of Clinical Psychology, the Older Adult Mental Health Service in NHS Grampian. This module is Therapeutic Lies. What is a therapeutic lie? This topic can feel like a very tricky area for many of us working with or supporting people with dementia and their carers. There are various terms used to describe this communication strategy, such as compassionate truth, compassionate deception, telling a non-truth, or therapeutic fibbing. For the purposes of this video, we are using the term therapeutic lie, as it is commonly used in dementia literature and within the framework we use in NHS Grampian. Therapeutic lies can inform an important part of dementia care due to cognitive difficulties, including time shifting. Entering the person with dementia's reality may involve going along with incorrect ideas or beliefs, and that can be the most compassionate approach, rather than orientating to our reality, which might be frightening for the person with dementia. Therapeutic lies can be used as a compassionate, proactive and preventative communication strategy, but this is only the case when we are truly stepping into the person's reality. The idea and concept of therapeutic lies in dementia care is a very complex issue and topic, which needs to be considered at an individual level for every person that we work with. So when might we use therapeutic lies? Therapeutic lies should only be used as a last resort when alternative options are not appropriate, when anything else would increase the stress for the person with dementia. And therapeutic lies should be used in conjunction with other proactive and preventative strategies. The use of therapeutic lies should be documented thoroughly in every individual person's care plan or notes. The use of therapeutic lies should also be agreed with the individual person's family members and anyone else directly involved in their care. It's particularly important to consider next of kin and power of attorney being notified of the use of therapeutic lies. So, how would we recommend utilising therapeutic lies in practice? When someone with dementia is experiencing stress and distress, we initially want to attempt to meet the person's need. So what need may the person be trying to communicate or meet in the moment? For example, asking for their parent, who we may know has passed away, the person might be indicating a need for comfort, safety, or warmth. We then would like to try and substitute the need. So continuing on from that example, we obviously cannot directly meet the person's need of being with their parent, but are there any ways that we can substitute it, such as reminiscing about their parent or looking through old photographs? If meeting or substituting the need in a person-centered manner has not successfully reduced the person's distress, then we may consider using validation and meaningful distraction. So what are the person's hobbies and interests, and is it possible to offer any activity related to these in the moment? If none of the earlier interactions successfully reduce the person's distress on multiple occasions, then it may be appropriate to consider the use of a therapeutic lie. A key component of each of these interactions is that they are meaningful and person-centered. Let's look at an example of using a therapeutic lie in practice. This is Agnes. Agnes often asks care staff where her mum has gone. Care staff know that Agnes's mum passed away over 30 years ago. They find that currently when they remind or tell Agnes this only increases her distress and she often becomes angry and she does not believe staff, is in Agnes's reality. She is in her 30s and her mum is still alive. Agnes often becomes tearful and then re-experiences the loss of her mum. Normally, by following the steps in our previous slide, meeting Agnes's need of comfort, substituting the need, and validating and offering meaningful distraction, such as activity or reminiscence, this reduces Agnes's stress and distress. However, recently, Agnes's dementia has progressed significantly, and staff are finding that these strategies are no longer successfully reducing her stress and distress symptoms, and Agnes is sadly no longer able to engage in activity as she once did. With discussion with Agnes's family, power of attorney, and staff involved in Agnes's care, it has been agreed that the most compassionate approach is to enter Agnes's reality and use a therapeutic lie. Therefore, when Agnes is looking for her mum and asks staff where she is, staff have agreed to say, "I haven't seen her today." And they may follow this up with additional questions related to Agnes's mum, such as, "Does your mum have a job?" or "Tell me what she is like." There are various important things to consider while utilising therapeutic lies. We must ensure that all staff involved in the person's care are using the same therapeutic lie consistently. We must also ensure that any therapeutic lie makes sense in the person's world and is also person-centred. So for example, if someone is told that their family member has gone to the shop every day for around 4 days, they are likely to become suspicious. Or if a woman is advised that her husband has gone to pick up the kids, but her husband always worked full-time so was never able to do this, she is likely to become suspicious of staff and potentially become more anxious. We must ensure that all therapeutic lies are therapeutic and serve a compassionate purpose, and they are not simply a lie to make our own lives easier. Therapeutic lies should only be told if in the best interests of the patient. Family members must be involved in the decision-making of using therapeutic lies. We should seek consent from family members, next of kin, and power of attorney. Some further important things to consider include: therapeutic lies should be used consistently by family members and all staff involved in the person's care once agreed. So for example, a member of staff telling a resident that their mum has gone to the shop, but someone else telling the resident that their mum is working, will likely increase the person's stress and distress symptoms and suspiciousness. Therapeutic lies, their rationale and use, must be documented in detail in each individual person's care plan. This should include circumstances where therapeutic lies should and should not be used. We must also ensure that where appropriate, capacity assessments have been conducted. It is quite likely that if the person does have capacity, therapeutic lies are unlikely to be effective and will again likely increase stress and distress in these circumstances. Given the complexities of using therapeutic lies, here are some final important reminders when considering using them in practice. We must be compassionate, validate and acknowledge the person's feelings, utilise meaningful distraction, and enter the person's reality. It's important to consider the use of therapeutic lies in the context of the psychological needs model, the biopsychosocial model, and the iceberg model. If you aren't familiar with these models, please see other videos in our Stress and Distress webinar series. It's also incredibly important to remember that therapeutic lies should only be used when they are agreed on by family members and other people involved in a person's care, particularly next of kin and power of attorney. When using therapeutic lies, we must always remember these points. Only use therapeutic lies if other proactive and preventative approaches are not reducing distress in the person with dementia. And a therapeutic lie should be agreed on and used consistently by everyone who comes into contact with a person with dementia. If you require additional support in managing stress and distress, please contact your GP or community mental health team for further information. Thank you for listening. You've now completed our video on therapeutic lies. Please move on to the next video in the playlist.